So this is definitely different. Elizabeth Platz is a professor in the department. She's my deputy chair. She's the Martin Abeloff Scholar on Cancer Prevention and Control. And she is probably one of the world's experts on the etiology of prostate cancer. So with that, I will
Great,
turn it
thank
over
you.
to Elizabeth.
Which I'm not going to talk about today. I'm going to talk about cancer screening. And although I do want to point out someone in the audience, so Don Coffey is here, so he is the world's expert on prostate cancer. So I'm glad he's come over from across the street today. So what I'm going to talk to you about, though, is cancer screening, the challenges and dilemmas we've been facing over the past few years. So you may have noticed in the news almost every day there's information about cancer screening, and the information seems to change from moment to moment. So I'm going to discuss what's been going on in our world and what we're trying to do to actually fix problems associated with cancer screening. So I'm going to go through the challenges and dilemmas. I'm going to talk about some of the screening successes that we've had as a nation. I'm going to talk about who we may be missing but who could benefit from cancer screening. And then I'm going to talk about our own obligations as researchers and as a health system for translating what we know about cancer screening and for innovating around new technologies to improve screening and decision-making about screening. Okay, so again, you see in the news constantly the controversies about screening for cancer. And so these controversies keep coming up because the recommendations change, and they change because evidence changes. And because the evidence is changing, and there's always a little bit of nuance to them, opinions form, and then different professional societies and other authoritative sources come up with different recommendations, which then confuse the public. Okay, and so it's not just the public who are confused. It then becomes our providers, it becomes advocacy groups, and the survivors, the people who've been screened, had their disease picked up, they've survived their disease, they're now very confused. Did my screening help me or didn't it? Okay, should I have been screened? Should I not have been screened? Many of us were taught and learned that screening for cancer is necessarily, I'm going to say a good in quotes, okay, that it's always going to be beneficial, that it's not going to cause harm. But we forget, and we forgot to tell the public, and this is both the medical community and the public health community, we forgot to tell everyone that there can be harms. It's not that every time there's harm, but there can be. There is the potential for harm. So we pick up disease we should have never picked up. Okay, so we can cause a physical harm by diagnosing disease that would have never caused that person to become sick and die later. Okay, there are also psychological harms. Imagine being screened, you screen positive, you now think you have the disease. You then go through diagnostic workup and you're negative. So do you have the disease or don't you? You're always going to remember that you screened positive on that test, even though you don't actually have the disease. And then there's the healthcare burden. There are costs associated with screening, with over-screening, and the downstream consequences. Okay, so screening isn't always good, so we have to remember that, and we have to remember to educate everyone that there are potential benefits and there are potential harms. Okay, so what were some of the changes to the screening recommendations most recently? So the first one is that it's now recognized that screening at the oldest ages may not lead to a benefit. Okay, so people have competing comorbidities later in life. They may die of something else first. Therefore, for some cancers, the recommendation has shifted. There's now an upper age range. Now, it doesn't mean someone who's beyond a particular age range can't be screened, but these are the general population recommendations. This is true, for example, for colon cancer and for breast cancer. So for colon, at age 76 to 84, we now say discontinue routine screening, but there could be a conversation about whether screening could take place. And then for those who are 85 and older, screening is no longer recommended. Okay? The other type of major change that we've seen is to the lengthening of the interval for screening. So it used to be many types of screenings were annual. Okay, Pap test, that was annual. Mammograms, that was annual. So now the recommended time span has been lengthened for breast cancer screening to every other year, and for cervical cancer screening, depending on the person's situation, either 3 or 5 years. Now there may be other higher risk women, but for a general population, either 3 or 5 years, depending on the tool being used. Okay, now where are the controversies? Those were not so bad. Although I can tell you, one of my colleagues, when we talked about the upper age range for screening, This is another epidemiologist. He got very upset because he was in that age range. And he said, my care should not be withheld from me. Okay, so we all think this way. All right, so what were the more controversial changes recently? So the first one was for breast cancer screening. The recommendation, this is the U.S. Preventive Services Task Force, is now to not screen without a conversation for women who are 40 to 49 years old. And there is an individual conversation and decision-making that should take place. So it's no longer a routine recommendation. Women hit the roof. The radiologists hit the roof. Okay? And then for prostate cancer screening, there was a change a few years back to say that men above 75 should not be screened. Okay, actually after 7 should not be screened. But then the recommendation changed again to the use of PSA testing should no longer be done for prostate cancer. In other words, we do not screen for prostate cancer any longer. That's the recommendation. Men were hysterical. Doctors were hysterical. The American Urological Association was hysterical. Okay, so here's the controversy. You can go to one of the websites. There's the radiologists. They basically said women are going to die if you don't screen them between ages 40 to 49. Okay, they were very upset. And I think you may have seen this article, or at least heard about it on the news. This is just this year in February. There was a long-term follow-up of a screening trial in Canada. This is a breast cancer screening trial that found that the women who were randomized to mammography did not have a long-term mortality benefit from that screening. Okay, so basically no difference in mortality from breast cancer after long-term follow-up in those who were screened versus those who weren't screened. And the investigators identified harms associated with that screening, and that was primarily the over-detection of disease that would have never caused harm to those women. Okay? So lots of controversy, and this is in the age range 40 to 49 and also 50 to 59, where the current recommendation is to screen women. Okay, so going forward, the U.S. Preventive Services Task Force is making sure they engage with stakeholders. Okay, now they've always done this, but now they're making sure that they're actually doing it. They have an open period for comment. They're letting everybody know. If you go to their website, they're letting everybody know that they should comment. And there's some lovely quotes from the chair of the U.S. Preventive Services Task Force. She basically wants everyone to understand that we understand it's important and that women care and we want to do the right thing for women. Okay, for prostate cancer, why did the recommendation change? It changed because of 2 large trials, one in Europe and one in the U.S. Okay? The screening tool, PSA, does pick up prostate cancer, no question about that. The question is whether or not by screening we reduce prostate cancer mortality. The European trial says yes, the tool does reduce prostate cancer mortality, but at the risk of great harm. In other words, lots of men are detected. Lots of men need to be worked up for the disease, and lots of men need to be treated for the disease. But much of that is over-detection. Okay? But there is a reduction in mortality from the disease. In the U.S. trial, which was conducted on a background of screening, we already had routine screening in the U.S., no benefit was observed. Okay? So recommendation changed. There's a recommendation against PSA-based prostate cancer screening. And again, the U.S. Preventive Services Task Force is very clear that they care. They didn't do this. They didn't make this recommendation despite men. Okay? It has to do with looking at the potential harms balanced against the benefits, right? We want the benefits to be high. We want the harms to be low. And so I think it was very nice on their website. It actually says that the members of this task force face the same concerns and fears about health challenges as other people. Okay? So the decision was reached after reviewing the evidence and much discussion. And so here's the reason for their recommendation. Good evidence that screening can pick up the disease. It can pick up the disease early, but the evidence is not conclusive that by picking up the disease early, it'll improve health outcomes for these men. And they noted a huge number of potential harms. Okay. All right, and so here's an example, and I'm going to throw out a little epi concept here. So here's a letter to the editor of a family practice journal. A man who was 43 years old was screened. He had prostate cancer. He said prostate cancer screening, PSA screening, isn't nonsense. It saved my life. Well, here's the epi concept. He doesn't have the counterfactual state. He doesn't actually know what would have happened to him had he not been screened, but he felt like his life was saved because he was screened. Now, we don't know which is the right answer, and that's the problem. right? We're observing. We can't know the counterfactual state. Okay, how about lung cancer screening? Well, up until a few years ago, there was no evidence that screening to pick up lung cancer early would benefit people. But then in 2011, the NLST was published, and that trial showed that those who were screened using low-dose spiral CT had about a 20% lower lung cancer mortality. But if they screened positive, which was 24.2% of the participants, 96% were false positives. Okay. So what are we going to do? Well, the U.S. Preventive Services Task Force reviewed the evidence. They concluded, they recommend now that we should be screening for lung cancer if you are a smoker and have the other eligibility criteria for that trial. Now, they are much more careful now. There are lots of extra sentences here that say, for example, screening should be discontinued once a person has not smoked for 15 years or longer, or they develop another health problem that will substantially limit their life expectancy, or willingness to undergo surgery if indeed they do have lung cancer. Okay, so now the U.S. Preventive Services Task Force is being very careful. These are no longer blanket recommendations. Okay. Nevertheless, as this screening becomes implemented, we're going to have to deal with weighing the benefits versus the harms, the over-detection, and the false positives. And this is going to lead to large healthcare costs. All right, so let's move on to successes. It's a whole lot of background. So what are the successes? Well, we've seen declines in cancer mortality rates due to screening. And we've had the success as a nation of including cancer screening as a preventive service without cost sharing under the Affordable Care Act. And so here's an example, colorectal cancer. And I think you can see notable declines, it's the green line, green curve, for both men and women. So that the first one was women and men. Okay, notable declines in colorectal cancer mortality rates. And these are largely attributable to screening, primarily with colonoscopy. Okay, how about cervical cancer? Now this says uterine cancer. It used to be for mortality, uterine, meaning the whole uterus, and the cervix, just the component that we care about for this particular cancer, were not separated for mortality rates. So they're still combined here. But this large decline is the cervical cancer component, a huge decline. And this is largely attributable to screening. And we hope in the future we'll have additional declines through vaccination against HPV. And we hope these types of declines will happen around the world as well. Okay. How about for prostate cancer? So it's this yellow curve. So what's causing this decline? It turns out, despite the controversy around PSA-based screening, we think this decline, in fact, is due to screening coupled with better treatment for men who are diagnosed at a very late stage. All right, here's another success story closer to home. So in the state of Maryland, this is colorectal cancer screening. Okay, look at the tremendous declines in the colorectal cancer mortality rate just over a relatively brief period, 1995 to 2010. This is a major success story. Okay, in fact, the CDC reported that our state had the greatest rate of decline in colorectal cancer mortality rates of all the states. Okay, so this is a huge success story. So how did we do it in the state? Well, it turns out we had a major uptake of colonoscopy or sigmoidoscopy. And how did that happen? Money. The state dedicated a huge amount of money for a long-term program to ensure that the underinsured and the uninsured could access colonoscopy. Okay, so sometimes it takes true public health dollars to make this type of difference. Okay, this is real dollars, not small program, long-standing, continuous funding. All right, so moving on to the Affordable Care Act. So I hope you all know this, that health insurance providers must cover, without cost sharing, certain preventive services. And these include some cancer screenings. So if you'd like to take a look, there's actually a website you can go to and figure out which ones apply to you. Okay, and so which services need to be covered? Well, those U.S. Preventive Services Task Force recommended services that are given A or B rating must be covered. Okay, so now here's the question. We're going to have many more people coming into screening which means many more people who need to undergo diagnostic workup and treatment. So how are we going to manage these costs? How are we going to have the capacity to even screen and treat everyone? Okay, these are major things to think about. Now let's think specifically about lung cancer. If we were to screen every smoker who meets the NLST criteria, and we know we're going to have huge numbers of false positives, how are we going to manage them? Right, a lot of cost, a lot of capacity will be required. All right, so who are we missing who we could benefit from cancer screening? Well, certainly for cervical cancer, the uninsured. Okay? This should be improved with the Affordable Care Act. Okay, people will have access. We'll have to figure out how do we increase uptake, though. All right, so here's the state of Maryland. Last year, only 64 women died of cervical cancer. That's a huge, huge success. But yet, should any woman ever die of cervical cancer? No. We have a tool that's very effective. It means we're not reaching some women. So in the state of Maryland, here's 2010, over 90% of women were up to date on cervical cancer screening. By the way, this is the Healthy People 2020 expectations of the goal, 93%. Okay, so we're getting close. But the question we need to ask ourselves is, who are the 10% of women who have not been screened in our state? And those 64 women who died, did they die because they were never screened for cervical cancer? Did they have delayed or poor quality of treatment? Or was their disease just very aggressive? If it's the first two, those deaths would have been avoidable. Okay? And so I just want to, periodically, I'm going to show you photos of people from the Cancer Epi group who are actually trying to address some of these questions. And so this particular question, who the 64 women are, is being addressed by Amber D'Souza from Cancer Epi and her doctoral student, Sally Pepra. Okay, so how about colonoscopy? Certainly we have a disparity by race, even among the insured, and then the uninsured, the uptake is very low. Okay, you imagine it's expensive to have a colonoscopy. Again, Affordable Care Act will increase uptake, but how are we going to get people into screening? Okay, so here's the state of Maryland once again, about 70% up to date. That's great. As I mentioned, here's the Healthy People 2020 expectation, the goal, so we're there. But despite that, so we have 70% of Marylanders being up to date. That means we're missing 30% of people. Who are these people? Is it that they don't want to have a colonoscopy? They're kind of nasty. So maybe we need to offer a different kind of screening tool. Let's go back and think about stool-based tools. The CDC is starting to embrace this idea, and I think we need to do that too. Okay, so the next area is our obligation to translate what we know and what we've discovered into the population. Okay? And so as a research enterprise, we have to go back to thinking about translational cancer epidemiology. So as David mentioned, I'm an etiologic investigator, but I now wear a variety of hats that make me think more about actually making a difference. So I lead our cancer prevention and control program over at the Cancer Center. I'm the head of the Maryland Cancer Collaborative, right? So I now have to think in a very different way, which is why my talk is not about telomeres and these other things that I study on a daily basis. It's about how we're going to make a difference, in this case for cancer screening. So we do have this obligation. And so we have a group called INCAS, Optimizing Cancer Screening in Hopkins Covered Lives. And this is a joint effort between our healthcare system and our researchers to actually figure out what are we doing with respect to cancer screening, how can we make it better, how can we implement it in the right way with quality, how do we monitor it, and how do we disseminate what we've learned to other healthcare systems. And so I want to point out that INCAS is part of Hopkins in Health, and Darcy Phelan Emmerich, who's in Cancer Epi, is the program director for InHealth. Okay, we have many of our faculty from Cancer Epi involved, and many of our Epi department students are also involved, as well as our medicine colleagues and basic science colleagues, and our health system colleagues as well. And so here's an example of how we're going to try to tackle that 30% of people who haven't been screened. So we've partnered with the Urban Health Institute to identify who are these people and what are the barriers to uptake. And this is going to be done primarily through a focus group approach. And then we're also partnering with the health system to determine who's not being screened within our own system figure out why they're not being screened, and to figure out how to encourage screening, including by offering stool-based tests. And this work is being done in part by Corey Joshu, who's in our department. All right, and just to show you a little bit more research that's ongoing related to cancer screening by Epi department faculty or faculty who have a secondary appointment. So when the guidelines for prostate cancer screening were changing, we realized the providers had no idea what to do. And so do they screen older people? Should they screen people with comorbidities? What should happen? So Craig Pollock and the team, which included Johns Hopkins community physicians, investigators, we actually surveyed the providers to find out what they would do about discontinuing screening of their older populations. And it turned out they didn't know what to do. The patients were still demanding, even though the guidelines were shifting. Okay, so based on that work, Craig and others are now doing a number of next steps. One is they're implementing a life expectancy calculator within JHCP. So the idea is if you're above a certain age, maybe it's time to stop screening. The problem is, beyond age, some people are very well and some people are less well at younger ages. And so there's not a tool to estimate life expectancy. They're incorporating one. The other thing that they're doing is they're developing a clinical decision support tool to help figure out who ought to be screened, because we're not wanting to throw away the test altogether. We just have to target it better. Okay, another area is breast cancer mortality disparities. So this is Kala Visvanathan and her colleagues. They know that screening for breast cancer is high, okay, in the state of Maryland, in both blacks and whites. And yet the mortality rate for breast cancer is much higher in black women. And so what their team wanted to know is, can they find a way to screen women who are at higher risk because of their race, because of other attributes? And so they thought one way might be to perform mammography while a woman is an inpatient at one of our hospitals. So they surveyed women. And it turned out 68% of the non-adherent women, if they had been offered a mammogram, they would have said yes to it. And they would have been willing to pay for part of it as well, which was interesting to know. Okay, so this work was deemed very important. The next steps are more money has been given to them to pursue this in more detail, and they've been connected to the health system to figure out how we can actually start offering mammograms to women when they're inpatients if they're non-adherent. Okay, and then the last bit is about innovation. Okay, so as researchers, we have the responsibility to innovate, to figure out how can we better test for cancer, to pick it up early, okay, through novel screening tests, new algorithms and clinical decision support tools, and also promoting behavior change for those who are resistant to screening. And I can tell you that even our most famous basic scientists here at our institution, Bert Vogelstein and Ken Kinsler, who used to be very much about treatment only for cancer, they've now shifted their perspective. They now say that secondary prevention should be plan A and treatment should be plan B. And so there's now a lovely collaboration that's been built between our cancer epidemiologists and these basic scientists. And so in particular, Corey working with Bert and Ken, she's bringing epidemiologic design and populations and biospecimens to test with correct temporality these markers with cancer. Okay? And because of our INCAS effort, there's now the ability to have the test moved into our own health system to actually see if it will work against colonoscopy. Okay, so I'm getting close to finishing. So what do we need to do to resolve these issues, these dilemmas that we've encountered with cancer screening? Well, the first one is we have to re-educate our stakeholders about both the benefits and the harms of screening. And we need to educate them about the need to change recommendations as evidence builds or as the evidence changes. We also need to target our screening efforts to those who would most benefit, including those who have been missed. So that rather than having these sort of blanket screening recommendations, they need to be targeted. And we definitely need to innovate and translate, and we need to do this by partnering with other disciplines, with our health system, and other stakeholders. And we need to think about setting lofty goals. For example, should we think about and promote the idea of eliminating cervical cancer globally altogether? Not just reducing the rates, but eliminating it altogether through screening programs and vaccination. And for colorectal cancer, okay, we have the rates are declining, but did you notice the disparity, right, isn't coming together? the rates are coming down together. The disparity is not at all decreasing. So what we need to do is think about providing high-quality screening and follow-up. And we can do this in part by developing new tools that have a high negative predictive value. Really remember the definition of negative predictive value? Right? So you want tools that will allow us to do a non-invasive, quick, simple test and only send those on to colonoscopy and more expensive care if it's more likely that they will end up with the disease. Okay, so that's it. So lots of dilemmas, and I hope someday we'll be able to resolve them. So thanks so much. Don Coffey.
I want to compliment you on this amazing effort of something that's so much needed in all this field. The biological false positives are so immense. And what happens to those people, both psychologically, money, and multiple biopsies. And those biopsies also cause infection, as you well know.
Yes, they do.
Especially in the prostate area, they come through the colon.
Yep.
And so we have to improve all that. Improve the operation, improve the whole thing. But we are going to have to go to some very much automated system on these markers and things that will eliminate the biological part of it. For instance, pathology is still done like it was done in 1910 by looking at the shape and abnormal spread of the cells. It's being shown over and over that can be quantitatively analyzed, and when the pathologist dies, the expertise do not die. They're locked in the screening thing. And that's going to happen, plus Bert's and that group's ability to see unusual DNAs, RNAs, exosomes, all these interesting things. And so this group is poised, I think, to really make that interface happen. And you have been doing that, and I salute you.
Thank you, Don.
That's an endorsement.
Anyone else?
Dr.
Dr.
Sullivan.
Platz. So one of the things that's so difficult is communicating this idea that cancer screening in particular can have harms. So what are the things that we can do as a public health community to help? I mean, I've had very difficult conversations. How do you explain to someone that no, potentially that mammography is actually harmful? Maybe you shouldn't have a mammography. I mean, that's a very hard message. So how do, as a public health community, how do we address that really complicated and difficult issue without seemingly like we're denying value?
Right, because that's exactly what people think we're doing, right? Because all of these controversies arose at the same time as the Affordable Care Act was being debated, right? And so it's a great question. So in the medical community, there's not enough time to hold this conversation with every patient, right? And so I think we're just going to have to do what we originally did, which was public service campaigns. When we promoted cancer screening in the first place, we had quite powerful messaging, right? Do you remember, I don't know, do you remember the idea of breast self-exams? So it used to be women were told you have to have the hang tag in your shower, and this is something that you have to do. You were made to feel guilty if you didn't do it, right? These were powerful messages. It turned out when there was a big trial that actually tested breast self-exam as a tool to reduce breast cancer mortality, there was no difference in a randomized trial. And so that recommendation went away. It's not that women shouldn't be aware, but the recommendation for routine use went away. And so what we need to do is have the same kinds of campaigns and make it clear that we're not taking away care, we're better targeting care. That's the key point, we're better targeting care. Yeah. Good question. Good, thanks.